in the infusion suite, before you even get started, you have to do your checks, just like you do with a regular systemic infusion. You're going to be doing your assessment prior to starting the patient, their physical assessment. You're going to be looking at your orders to make sure everything looks right. You're going to look at the lab work. If it's the first time you're seeing the patient, obviously you want to check for catheter tip confirmation.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS. And today we're talking with Emoke Karonis, Clinical Nurse Specialist Fellow at Memorial Sloan Kettering Cancer Center in New York, New York, about nursing considerations for intraperitoneal administration. As a reminder, you can earn free NCPD contact hours after listening to the episode today and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Emoke.
Oh, thanks for having me. Very excited to be here.
Well, to start our conversation today, let's just start at the beginning. Can you briefly describe what exactly is intraperitoneal administration of chemotherapy, or maybe even a non-chemotherapy? And moving forward, just for brevity, we will refer to that as IP chemotherapy or IP administration from here on out. So how exactly is it performed? How does it work differently compared to what we're more familiar with in the standard intravenous administration?
Intraperitoneal therapy, it's basically just the administration of an agent, and that could be chemo, that could be CAR T cells. We've given oncolytic viruses this way into that space where the abdominal organs float around. And you could do this via an implanted port, like a metaport, which we're very used to seeing. That's completely enclosed by the skin. Or one of those direct intraabdominal catheters like a Tankoff. And that has a portion that's always present outside the body, and that needs addressing. Patients with cancers that have metastasized to peritoneum, who've either had like a debulking surgery and have very little disease left inside, or small tumors to begin with, they can be considered for intraperitoneal therapy. It's really intended to treat very small tumors, small disease, generally less than a centimeter. And this is because the drugs work by diffusion through the tumor surface and then enter the bloodstream via the capillaries. These drugs can only penetrate like a couple of millimeters below the tumor surface. And we have to pick drugs that clear slowly from the peritoneal cavity to deliver a high drug concentration to the actual tumor. But then if it enters the bloodstream, it has to clear really quickly from the plasma to avoid any toxicity. And it's generally considered to be a neoadjuvant regimen.
Thank you for that explanation. That's definitely very helpful, and certainly not a treatment that all oncology nurses are familiar with, because it is used maybe for only specific types of diagnoses or in certain settings at different points of the care, the treatment pathway. And so I don't know that it's as commonly known or people feel familiar or comfortable with it when it does sort of come across their setting that they're working in. So let's talk a little bit more about those specific diagnoses that might consider IP administration as possible treatment. And then what also are the most common agents or drugs that are used in those regimens?
So actually, IP therapy has been around a pretty long time. It's been around since the 80s. So a vast number of diagnoses have been treated with IP therapy, but most commonly it tends to be the ovarian group. Along with that, the appendiceal cancers, things like fallopian tube, peritoneal, some soft tissue sarcomas, mesothelioma, gastric cancers, colorectal, Wilms tumor. IP therapy, it really does seem to go in and out of favor every couple of years, depending on what the current menu of drugs are available. For example, recently Avastin, bevacizumab, has impacted the ovarian IP regimens to be used less often. If you're someone who can get bevacizumab, you're less likely to get IP therapy. But if you can't get Bev, then you might be a better candidate for IP therapy. So there's more wiggle room like that. Drugs that are given via this method, they include the taxanes, Taxol, Carbo, cisplatin, We also give doxorubicin, mitomycin, methotrexate, gemcitabine, melphalan, 5-FU, tolbicides. Surprisingly enough, because we're not giving these drugs systemically, we can give massive doses via this route, the intraperitoneal route. Cisplatin can be given at like 10 to 20 times your usual IV concentration, which is kind of mind-blowing. And IP Taxol has been given at 1,000 times the IV concentration. So these doses, when you get this bag up from pharmacy, can really kind of throw you for a loop. The peritoneum does act as a barrier to the systemic absorption, so that also increases the overall tumor exposure to those drugs. And since the body's not being exposed systemically to the drugs at the same concentration as like IV, the liver's going to metabolize those drugs at the first pass, and it gets kind of cleared very quickly. So it also means you can't just give anything IP. You have to give something that is going to clear from the plasma very, very quickly.
That makes complete sense. And I like how you mentioned, and I agree in terms of it kind of coming and going in, I don't want to say popularity, but it's kind of all the rage, and then something else comes along, or we do additional studies and research and realize that perhaps another less toxic therapy is equivalent and produce maybe similar outcomes, but without some of the toxicities and things. And so my experience in ovarian cancer is very much what you said. In the early 2000s, it was definitely, there was a big push to make it more of a standard of care. And then as bevacizumab and other regimens have come along, it sort of still exists. It's still part of the NCCN guidelines as an option, but certainly not the absolute, everyone must get it. It's got to be this way or no way. And so just highlights the importance of staying aware of how guidelines change and just always being ready to potentially give this treatment if it is the right fit for that patient, given whatever their diagnosis is, as well as contraindications they may have or comorbidities. So not something that every patient gets all the time, but something that's going to pop up sooner or later, and you're going to need to know a little bit about it. So I think we'll learn a lot today.
Yeah, especially, as far as like the regimens, for a while, oncolytic viruses were very hot, and they were being given via this route.
Absolutely. And things change quickly. So before we move on and get too deep into the details about IP administration, I want to pause just for a second and ask a question about a similar but different type of treatment called hyperthermic intraperitoneal administration chemotherapy, or HIPEC is usually how that's abbreviated. How is standard IP administration that we're talking about today, how is that similar or different from HIPEC?
So HIPEC is something that's done in the OR. And that is done right after the surgeon has done all their tumor removal. It is hyperthermic, meaning that the stuff is hot, and it gets administered via a special circulating machine that heats up the chemotherapy and circulates it throughout the abdomen. It has like an in and out kind of catheter set up that goes into that actual peritoneal cavity. It gets closed up very loosely. And usually it's drugs like doxorubicin or cisplatin or carboplatin. They're heated up and they're circulated for about 90 minutes to 2 hours. Sometimes they even put the patients on a cooling blanket if they're at risk for overheating, because those drugs can be as hot as 42 degrees Celsius, which is like 103 degrees Fahrenheit for us. Afterwards, once they're done, the abdomen is rinsed out with saline to get any residual drugs out of that cavity to reduce any toxicity that could happen afterwards. The premise is that there could be tumor seeding after the surgery, like there could have cells scattered throughout the abdomen afterwards. So if you're circulating the drugs throughout the peritoneum after the surgery, you might be killing whatever could have gotten scattered immediately after the debulking. And the aftercare is whatever's typical for that patient that had abdominal surgery, whether they had some kind of a GI intestinal resection or if they did anything involving the vaginal wall or anything like that.
Well, thank you for explaining that. I think it's important. Certainly sounds like that it is similar to IP chemotherapy. Well, of course, it's hotter. It's infused in a hyperthermic state. And also it's somewhat of a temporary dwell where it's infused. It's allowed to sit and sort of marinate. And then before they are closed up after their surgery, then that is removed. So sounds like some very similar processes in terms of how it's administered. Obviously, the setting is the OR. So some notable differences as well. But I think it's important to create those parallels just so that nurses have that context and that frame of reference of, how do these different therapies compare and contrast? So thanks for expanding on that. So as we talk a little bit more about IP chemotherapy and the administration of these agents, What determines if a patient is eligible or an appropriate candidate to receive a treatment in this route, if it is in fact a recommended treatment option for their type of cancer?
So these patients, they have to be able to tolerate the insertion of that port or that catheter. They have to be able to tolerate whatever that additional pain might be while they're healing. Also, the healing process itself. Is this a person who has like really poor nutritional status? Do they have like very low albumin? That's also going to affect their ability to heal and have that catheter remain patent. You can't have too much ascites going on. People with massive abdomens are not good candidates for intraperitoneal therapy. Also, the choice of the type of catheter that the surgeon's putting in. It's an implanted port, you might be able to get away with a little bit more, but if it's something like a tank off, there's going to be a dressing that they have to manage. And do they have resources available to assist with that? They also have to have the ability to manage that device. Like they could have people that are confused. They may not be able to have that constant reminder of their disease. They could be pulling at it. There could be multiple psychosocial issues also going on, which would make someone inappropriate to have an implanted port.
And along those same lines, are there any medical contraindications that would potentially exclude a patient if they would not be maybe the best candidate for IP?
You definitely want people who are going to be able to recognize that there's something wrong. A person who can't recognize signs or symptoms of infection or have someone available to help assess them from day to day. Someone who has tons of adhesions from their surgery is also someone who would be contraindicated. A person with a lot of tumor burden, or if we know that they have a fistula, obviously that pouring fluid into someone like that wouldn't be a good idea. If someone has an intraabdominal abscess, also if the patient has like really poor renal function, that's going to limit the type of agents that could be instilled, especially with the platins.
Yeah, absolutely. I mean, I think in general, my experience is it's challenging. I mean, it's a challenging treatment, I think, for patients to endure. It is a little bit more involved than your standard IV regimen that you might come in for every 3 weeks or weekly. Sometimes it requires extra visits for fluids and for, side effect management. And so, I recall when preparing patients for this, just trying to emphasize that, there are some extra visits and some additional considerations for this type of treatment. Certainly not to dissuade them from going forward, but just creating that realistic understanding of what it entails. And I think, as you've mentioned, there are some physical, some psychological, some not socioeconomic, but there are some support needs that need to be there for a patient who is undergoing this type of treatment, because it truly is a little bit more extreme. I don't know, extreme maybe isn't the right word, but it's not as sort of cut and dry as an IV administration.
It's more intense, I would say, in terms of like the amount of attention you have to pay to what's going on.
Absolutely. So we've touched on it a little bit, but if we can maybe dive a little bit deeper in terms of the access devices that are used for IP administration, what are the options? And then how are these devices cared for during and after the IP infusion?
So generally, what we see most often is the vascular implanted port, like a metaport. It's not in a vessel. It's in that peritoneal space. It's still a subcutaneous port, but just like with a vascular catheter, it gets tunneled into a vessel. This is going to be tunneled into that empty space in the abdomen. You could also have something like a dialysis catheter, which is like a tank off, which is a straight catheter that has a cuff that keeps it in place. That one sometimes has a clamp on it, depending on what type of catheter they're using. As far as taking care of the catheter in the infusion suite, before you even get started, you have to do your checks, just like you do with a regular systemic infusion. You're going to be doing your assessment prior to starting the patient, their physical assessment. You're going to be looking at your orders to make sure everything looks right. You're going to look at the lab work, your CBC, your comp. You're going to be looking at the creatinine, magnesium, potassium, calcium tend to get kind of knocked for a loop with these patients. If it's the first time you're seeing the patient, obviously you want to check for catheter tip conformation. Not going to be in a vessel. It's going to be in the abdomen. So you want to make sure that especially if the person has more than one access device, that you are looking for the correct conformation. The person could also have a metaport on their chest wall. So you want to make sure you're looking at the right catheter. The implanted ports, they're accessed in a very similar fashion as the vascular port. You have to use sterile technique, prep your needle to clean the site, and you're going to be puncturing with a non-coring needle, just like a vascular port. It can be a little bit trickier to feel the septum than a typical vascular port because there is usually more subcutaneous tissue around this abdominal port than in your chest or your arm. It does tend to be sewn next to the costal margin, kind of up high, and they have a tendency to kind of flip almost underneath. So you may need to kind of press down and manipulate a little bit more than you're accustomed to. There can also be the presence of ascites, which can make feeling for that port challenging. So it is a good idea to be pretty comfortable accessing implanted ports if you're going to be doing this, or at least doing it with someone that feels very confident. The one thing that you can't do is you can't check for a blood return because it's not in a vessel. Aspirating, you can aspirate. ONS says it's okay. The Infusion Nurses Society doesn't recommend aspirating. Whatever your institution tells you to do, obviously you're going to do that. But if you are going to aspirate, you don't want to do it too vigorously because you can pull fibrin and proteins into it and end up clotting your catheter. So that would be a bad thing. You could also potentially injure someone if you pulled back too vigorously, as you can imagine. Also, it's not unusual to use really long needles, like 1.5 to 2 inches. You know you're in the septum based on how it feels in your fingers and feeling the back of that port once you access. Again, there won't be the blood return, so you have to kind of go by what you felt when you access that patient. And you're going to look up at your bag. And the big thing with the intraperitoneal therapy is you want to see a nice free flow of those fluids by gravity. We don't usually use infusion pumps with these treatments because you could potentially force fluid into an area with an adhesion, and that could cause pain to the patient. If you do have trouble, it's always a conversation you can have with the LIP if the flow of the fluids isn't really happening by gravity, but it's definitely not a decision you want to make independently. Another thing you're going to want to do is you're going to hang at least a half a liter of normal saline up there, and you're going to run about 100 mLs prior to actually starting your treatment. That's a good practice to allow you to assess your needle site and to check for pain, any unusual movement of the needle. It's a good idea to kind of loop the tubing so that if the patient repositions themselves, it kind of tugs on that little stress loop before it tugs on the needle on the abdomen. These agents are usually like in a huge bag of at least like 1.5 to 2 liters. And that's so that the abdominal cavity gets completely filled and exposes the entire peritoneal area to those drugs. It's really not unusual to administer like as much as 3 liters of fluid during these treatments. You're going to cover that area with an occlusive dressing and make sure it's, taped down really well. The patients do have to lay still, usually reclining, while the fluid is going in. And then once they're completed and you've disconnected them, if they can't stand up and walk around, then you're going to have them reposition every 15 minutes for at least an hour. If they can walk, then that's great because that's the best thing to get the drugs to move around. Before you deaccess them, you're going to flush it again. You can use heparin. You don't have to. And obviously, you're going to put a dry sterile dressing on there. If there's any leakage onto the dressing, that's considered hazardous for about 48 hours after the treatment. So you want to instruct the patient to double bag that, or if there's any leakage onto their clothing, to wash that clothing separately in hot water from their regular clothing. Of course, if it's more than, what you would expect on a regular 2x2, 4x4 gauze, if it's saturated, that would be a reason to pick up the phone and call the doctor.
That was some great information. I think it just goes to, those sites that do this frequently, likely an academic center or one with a strong gynecologic oncology practice, you will likely see more of this type of treatment. And so this all probably sounds very familiar, but for those sites that don't see that as frequently, just some great information that you've shared there. I mean, I think the most important thing is it really is the same kind of port, but there are some very important notable differences that you pointed out that you can't and really shouldn't be aspirating because you're likely to not get blood return. In fact, you should not get blood return. But that's, that is an instinct, right? If this is it feels like a regular venous port, but suddenly it's not in the venous space. So those are details that really require attention and thinking through what you're doing, even though it kind of looks and feels the same. But even as you mentioned, it sometimes doesn't feel the same because it's in a space that potentially, depending on, the body habitus of the patient, might not be as secure, even though they try to kind of attach that and tether that to the muscle layer underneath. So it doesn't kind of migrate and float around. It still can move. Not even the port, but the tail of that catheter also can move, become sort of lodged up against a variety of organs in the abdominal space. And so each time it's accessed and used for an infusion, there are, unique challenges that can present each time. I think you also made a great point of just the volume of fluid that is used in these regimens. I'm familiar with the drug itself being mixed usually in, 500 to a liter, but then also an additional liter of just saline being infused, again, because you need to fill that entire abdominal cavity. And depending on the size of the patient, that can change how much fluid you have to use to really ensure that all of those surfaces are being sort of bathed in that medication to really get the effect that's there. And that can be, I think, surprising for patients to see that much fluid going in. And also a cause for discomfort, right? Because we want it to fill up the abdominal cavity, but most people don't feel their best when their entire abdominal cavity is full of fluid. And so coaching patients about it is going to be uncomfortable and it might last for a couple of days as that slow absorption happens. One thing I experience as patients in the gyn-onc space, they've likely had a large debulking surgery, so they don't have their uterus. So there's even more space in their abdominal cavity than what they're used to. And, when you stand up, gravity pulls that fluid down. And so having edema and swelling in, the genital area or the lower abdomen area, they weren't ready. They weren't expecting it. And so just thinking through what has that patient already been through? What were their surgical procedures and how might that impact their experience, I think are important things to keep in mind as you're teaching patients on what to expect both during and after the infusion.
That's so right. And it underscores how important all that teaching is and how it is necessary to repeat yourself because we're giving them so much information at the pre-surgical visit. We're giving them so much information while they're going into the operating room, when they come out of the operating room on their discharge, and then they're going to go into the clinic for their post-op visit. And, there's just so much being thrown at these folks all the time that you do need to constantly reteach the same thing and to always be very neutral and accepting of that people may not retain everything that you tell them the first time.
Absolutely. So after a patient receives their treatment, we're fairly familiar with what the typical side effects are with many of these agents when they're given intravenously. But let's talk a little bit about the adverse events that might occur with the IP administration.
It's so, so important to maintain good sterile technique when accessing and taking care of these catheters in these patients. Peritonitis is horrible. It's so painful and it can be fatal. Peritonitis or even site infections that are just, around the site of the catheter itself, you could lose a catheter to infection. And in fact, that's the most common reason for losing a catheter for an IP patient. And if the patient loses their catheter, they can't get the chemo in their abdomen anymore. So they've entirely lost that option for treatment. So it has to be taken very seriously as you're managing it to make sure that you're scrubbing your hub and maintaining as good an aseptic technique as you possibly can. You could also have incomplete healing of the catheter insertion site. And it's not limited to just those tank-off catheters that are outside the abdomen all the time. Even the implanted port, you could have leaking at that insertion site. You could even have pocketing of that fluid between the subcutaneous tissue and the actual abdominal wall. I've seen that happen, and that's quite uncomfortable. Also, these patients, they could have their catheter obstructed. That can happen from fibrin, proteins floating around. It could also happen from just tumor pressing on the catheter. There could also be kinking of the catheter internally as well as externally. So you don't ever want to bend or twist the catheter if there's, an external line when you're securing it. Sometimes people tend to want to loop things. And when you loop things, it's really easy to create a kink. So you have to be very, very careful about doing anything that the plastic of the catheter is arguing with you about. It's also important to flush really, really well. Depending on your institution, you might be allowed to use heparin, maybe not. But if for some reason it's not flushing really well, it's okay to instill alteplase into these catheters after you have a conversation with the provider. And if for some reason it's just not flushing really well, it just doesn't feel right. So often we don't pay attention to our instincts as nurses, and we're usually right when we feel like something's not right. Don't ever, especially with these catheters, don't ever feel like you can't request a flow study or have the provider come on down and double check the catheter. You can always do a flow study. You can always have the patient come back. It's not ideal, but it's better safe than sorry. We want the chemo going into the abdomen, not into the subcutaneous tissue. Another thing that could happen with the IP catheters, especially if there's ascites, you can have leaking from around the catheter. And it's not unusual to actually have to back off from IP treatment and switch to systemic treatment until complete healing occurs. That's one of the reasons why ascites is one of those factors that we look for before we actually insert these catheters, because they could just spontaneously leak from those sites if there's a lot of pressure internally. Other things that can happen that are much less common, you can read about things like bowel obstructions and perforated intestines or necrosis from the catheter rubbing against the intestines, but generally it's felt to be as part of the disease process, like progression, as opposed to just the intraperitoneal therapy itself. The other thing that can also happen is the catheter could actually migrate out of the peritoneal cavity, like almost form a fistula. That's another thing that I personally have never seen that, but that is out there. And also the port itself could get separated from the catheter, just like a regular vascular catheter.
Essentially, anything that could go wrong with a regular catheter can go wrong here. Anything that could go wrong postoperatively could go wrong here. So it just highlights the complexity of what these patients are experiencing. They likely have just had an initial large debulking type surgery. Commonly, that port is placed at the time of surgery, sort of at the conclusion of surgery in preparation for that adjuvant treatment that comes next. And so you're balancing kind of standard post-op recovery, but also a new implanted device. And also then we're giving chemotherapy or some other therapy on top of that. So it is this sort of perfect storm of possible complications that just heighten, again, the complexity and the seriousness of patients who are going through this therapy, to make sure that they understand just all the various things that we're watching for, and certainly doing our best to hopefully prevent from happening at all. Or if they do start to occur, that we need to see them, identify them, and report them as quickly as possible, so that hopefully, whether it's infection or things like that, that we can preserve that catheter in place and hopefully be able to continue their treatment as ordered. Now, we talked a little bit about sort of the adverse events associated with just the logistics of the therapy. Let's talk a little bit about the specific side effects from that systemic absorption of those drugs still, even though they're coming from the inside, into the vessels, kind of from a different route. What are some of the common toxicities or side effects that we might see?
You can still have side effects with IP administration. There seems to sometimes be a misconception that because it's in the peritoneum and we're able to give higher doses, that they're less likely to have side effects. But we do still need to definitely pre-medicate these patients. They're still going to have nausea, vomiting, diarrhea, the usual neuropathies, depending on what drugs they're getting, mouth sores. Their counts are going to go down, neutropenia, thrombocytopenia. All these things can happen with intraperitoneal regimens. Platinum-based regimens, you're still going to be concerned about their hydration. You're going to be looking at their renal function on their labs, their I's and O's. You're going to screen them for ototoxicity. You're also going to be looking for the electrolyte imbalances. Magnesium's always low. You might lose potassium, calcium. They might get anemic. Also, sometimes we're due IP in addition to systemic therapy, sometimes even at the same time. And so you could just imagine we're going to need to be especially careful with those patients as far as pre-medicating them and managing them from day to day, because those intense regimens can be really quite something for those patients to manage. One other thing too, I always forget about this, but hypersensitivity, that's another thing that can happen with IP therapy too. And that is something that somehow, at least for me in my brain, always tends to fall into the back burner. You can have a hypersensitivity reaction with these drugs as well. So you need to be ready for that also.
That's a great point to keep in mind. I think the complexity when you're doing a regimen that includes both an IP component and an IV administration component. You mentioned this earlier, but just the importance as part of your standard process of reviewing orders and hopefully having all of those sort of environmental safety mechanisms with wristbands and scanning of drugs and anything that the electronic health record can contribute, but keeping those routes separate and distinct. Sometimes a patient will come one day for both an IV and an IP agent, and then the next visit is just IV or it's just IP. And so it's so important for nurses as they are leading that patient's visit for the day and being the one to understand the sequence of the agents that are on the orders for the day, just keeping very clear what is going IV versus what is going IP. Because again, these are agents that are commonly given intravenously, and occasionally now we're going to give them IP. So just creating that clarity around what is the patient's visit for today, reviewing their orders to understand what day of their cycle are they? Is this the right agent? Is this the right route? I don't think that can be emphasized enough because, as you mentioned, the doses are not what you would give depending on what route you're talking about. And so just staying very tuned into those details, which are part of our standard safety verification of knowing what drugs and what doses and what's appropriate for this patient. The importance of that is extremely heightened when you're talking about a complex regimen such as this.
You're absolutely right. You can't emphasize that enough. If there's one point where you need to slow down, take a breath, is during that independent double check. You have to be absolutely sure that that day that that patient is presenting to you in your suite, you are definitely giving what's expected for that day. Because you are right. If they're coming in multiple days, they could have a regimen that changes from day to day. We've all seen where it says cycle 1, day 2, we're doing this. Then day 3, we're doing something else. And day 4, we're doing something else. And it's so easy to get confused. And it's very important to go back and see what has happened before that patient showed up on your suite, and also what's expected to happen that day and what's going to happen the following day or the day after. You also have to be so careful that part of your independent check here at MSK is to actually trace that intraperitoneal line directly to the port with the nurse that you are doing your independent check. And it's not a bad idea to label it. I know that nowadays we're not supposed to be taping lines, but if there was something that you could use to flag that this particular line going to this patient is going into the abdominal port versus the vascular port, that's not a bad idea to do that.
Those are great recommendations. Absolutely. Do you have any other nursing best practices or just unique considerations that we should keep in mind during IP administration?
Part of the best practice is definitely educating the patient even before they walk into the suite. You want to tell them to eat very lightly the night before or the morning of that they're coming in. The more food they have on board, the more bulk they're going to have inside their abdomen, and that could lead to more discomfort while the infusion is happening. Generally, small meals the night before, the day of, the day after will go down better. They also need to be prepared as far as wearing loose clothes, sweatpants, that sort of thing. Before they show up, they need to have the right garb.
Sure, it makes sense.
Before they sit down, hey, did you go to the bathroom? Go to the bathroom first. And, in the meantime, you can prepare a gown for them. It's a good idea to have a gown for these patients because you are going to be assessing that abdomen very frequently. My personal experience is that having sweatpants on or trying to kind of manage with a shirt while this is going on is just not the best thing to do. It's a good idea to gown these patients. When they come back, you talk to them. This is a great time to talk to them about their side effects. Hey, what'd you eat last night? What'd you eat this morning? How are your bowels going? Are you constipated? Are you having trouble moving? Do you need help? Do you need to take something to soften your stool? Maybe this person's having trouble with nausea before they've even walked in. So we need to think about what they might need as far as pre-medications. Maybe they need some, anxiolytics or something before you even get started. And it's also really important to talk to them about their pain before you even get started. You have to set that baseline because if they do develop cramping or pain while that infusion is going into their abdomen, you want to be able to assess, is this new? Is this their baseline? It's part of knowing what you're starting from in order to know what a change is. Other things that are good things to kind of keep in mind, you want to make sure that patient is really comfortable. Try to keep the room kind of warm. You want to have warm blankets for them. You know how fluids are when they come up from the pharmacy. Half the time they're sitting in the refrigerator for an hour or two before you hang them. They're ice cold. You could just imagine what that feels like going into someone's belly. If you can, as much as you can, try to let them warm up to at least room temperature. Some institutions allow you to use a fluid warmer for pre and post dose fluids to distend the abdomen. If you can do that, that's great.
I've even seen where just you wrap them in a warm blanket just to kind of help at least get them, not through an official warmer, but just to warm them up, a little bit quicker so that they are comfortable infusing.
Yeah, definitely. I mean, nobody likes to be shivering, while they're laying there on that bed. It's bad enough they have to lay still, and then, you know, these fluids, they're not generally on an infusion pump. So this is one aspect that nowadays is somewhat unique. We're running these fluids to gravity. So you do need to monitor the flow of those fluids for changes. It could slow down as the abdomen is filling up. There can be pocketing inside that abdomen. So sometimes you need to reposition the person in order to get those fluids to keep flowing really well. You have to go in there frequently. You really have to pay attention, like every 15, 20 minutes, I would say. You might even need to change the height of the bag as the abdomen is filling. You have to look at this person's belly to make sure it's expanding symmetrically. There could be leaking that's happening while this stuff is going in. There's a lot of assessment that has to go on in real time. You also need to monitor the respiratory status. Are they getting short of breath? Maybe you need to lift the head of the bed a little bit to make them more comfortable. You also need to be assessing for pain, for cramping while the infusion is going in. And you have to also educate the patient to call you. What if all of a sudden they're having cramping? Don't wait. They have to call you right away if something's not right. Also, you need to explore their resources, how they're feeling about what's going on, managing that catheter, managing their life. The more they know about what to expect, the better their experience is going to be. And also, this is a very time-consuming regimen in terms of nursing time. Probably wouldn't be a bad idea if the nurse taking care of this patient could have a lighter assignment while they're getting started, especially if they don't have a lot of experience giving the intraperitoneal chemo, because it really does require you to go into that room and assess quite frequently. It's not like one of these situations where, you hang something and you'll be back in 30 minutes. That's definitely not going to be happening here.
Yeah, I think those are some great pearls to keep in mind as you're working with patients who are experiencing this regimen. One thing that I recall, and again, my frame of reference is in the ovarian space, and commonly patients would start on this IV regimen. And at some point, toxicities would necessitate that we'd have to kind of revert course and then stick just with IV. And so it's important, I think, for whatever the patient's scenario is to stay connected with how they're feeling and how they're tolerating it. Sometimes it's objective, toxicity where we can see on their labs or things that, this might be just too toxic and we have to either dose reduce or change course. And certainly that happens with conversations and consultation with the ordering provider. But, we know as nurses that patients will sometimes be more honest with us as nurses than they are with their physician. And so, talk to your patients. How are they really tolerating this? Are they doing okay? Or are they feeling like, man, I don't know that I can get to the 6th cycle or whatever the regimen is. And so just being that comforting ear for patients to be honest about, is this manageable? And I think all of the advice you gave about really just needing that potentially one-on-one assignment especially for the first 1 or 2 times a patient undergoes this therapy is really important, because it is going to feel very unfamiliar and very uncomfortable and probably a little scary for patients the first time they go through with something like this. There's just probably no sensation similar to what it feels like to get this type of therapy instilled. And so having a nurse there with them, reassuring them, being there to answer questions or intervene if they're having concerns or questions, just invaluable, and really is important to advocate for the patient that day and just be there so that they can hopefully get through that first experience successfully without complication. And so that sets them up for a good chance to continue their therapy moving forward.
Definitely.
Well, Emoke, as we approach the end of our episode, we like to always ask a few just quick fire questions to help summarize what we've talked about and give some pointers or tips as we conclude. So to start that off, are there any common misconceptions about IP administration?
Really, I don't think that there's misconceptions so much as it can be a little bit scary when, you're giving things to gravity. You do have to be familiar with calculating drip rates. And I'm sure we all remember from school, the drip factor and knowing the tubing and having to do that math. So that can be a little bit scary. And so you do need to have some confidence. It's not a bad idea to maybe practice if you haven't done it before. If you're older like me, you might remember a time when you didn't put a whole lot of things on machines. And nowadays, the guidelines put out by the various recommending bodies say to put everything on an infusion pump. So it can be a little unnerving to have to figure it out by hand for the first time. Also, this is something that can be done safely. So there's absolutely no reason to be terrified by the experience of accessing these ports and managing these patients. It's done safely every day. You just have to have the confidence accessing the lines in the abdomen. If you need help, you shouldn't be afraid to ask your colleagues or the doctor, the LIP, to help you assess a site. If you think there might be something wrong, you have to advocate for those patients if you think that they need resources.
What's something about IP administration or IP chemotherapy that's not often discussed, but you wish people knew more about or were more familiar with?
I think with this particular regimen, we don't see as oncology nurses peritonitis a whole lot. And we do need to talk about that because that is, besides the catheter, just peritonitis, infection of the peritoneal wall itself is very dangerous, very painful. You do need to be able to assess because the pain is a little bit different. It does tend to get worse with movement and it's more tender to the touch. And unless someone's actually feeling around the patient's abdomen in clinic, they may not pick up on that. That could be something that you would pick up actually inside the suite as you're accessing the patient. So again, that's like something that's very important to get that baseline and really investigate the quality of the pain that the patient may be having. Is it new? Is it old? How long has it been going on? Is this really the disease that it's something that's been there for weeks, or is this something new? So that would be something that you really do need to kind of keep in the back of your mind as you're accessing and taking care of these patients.
Absolutely. And I think, again, most of these patients have had some sort of abdominal surgery, whether it was recently or even with some relative distance, still trying to keep clarity around, is that, as you mentioned, is this a new pain? Does this feel like what that postoperative healing pain felt like? Or is this something new and different? So I think that's a great tip of just being more aware of that when these patients are getting this intraperitoneal treatment. For nurses that want to learn or understand more, what additional education and training do you recommend about IP administration?
It's not a bad idea to look at peritoneal dialysis information. That's where I got my first experience I worked on a peritoneal dialysis unit at my first job. You definitely, with that practice, you learn a lot about when it's appropriate to drain fluids from an abdomen, what kind of side effects you could be looking for, depending on what kind of meds you're putting in there, the different types of catheters. That's not a bad place to investigate, is the peritoneal dialysis world. Also, as far as if you want to learn more, it's definitely you need to check out the ONS, the Access Device book. They have a great resource for that. The Infusion Nurses Society has a few articles also on intraperitoneal therapy, which are really terrific. You need to be comfortable doing those drip factors and running things to gravity. So just even practicing, with a bag of saline, that's not a bad thing to do if you're trying to learn to understand or feel more confident about giving IP drugs.
I think that's a great recommendation of reaching out to sort of colleagues in the dialysis space. What a great sort of cousin to this type of therapy of just understanding and talking with nurses who are more familiar with procedures that involve similar steps and processes. And I think you had mentioned also before of just don't be afraid to reach out to the physician or the practitioners that are, more involved maybe on the, the postoperative side, the surgical insertion of the catheter, getting understanding of kind of how do they insert it? Where do they place it? Where should it be, within the patient's anatomy? I think just getting a more comfortable understanding of kind of where this catheter is helps to kind of connect the dots of, as you're giving this therapy, like how is it going to impact the patient? So reaching out to colleagues that have either given therapy through this route before and are comfortable and can help kind of take you along the steps as if it's your first time doing it, or reaching out to those experts in the space that can provide some other context to the administration, just again, to provide more information and more comfort. Well, Emoke, thank you so much for all of the wonderful information that you've shared today about a treatment route that I think is very, mysterious for a lot of people who don't give it commonly or don't work with patients who have the IP as a common part of their treatment regimens. And so thank you for shedding some light and maybe pulling back the curtain a little bit so we learn more about it. Is there anything else you'd like to share with our listeners today?
Not particular, other than there's a lot of really great resources from ONS about IP. Again, that access device book is great. The Infusion Nurses Society has information on intraperitoneal devices. Of course, there's the guidelines that are published by ASCO and ESMO. The CDC has guidelines for ovarian patients, the American Cancer Society, cancercare.org, the NCCN. There are a lot of resources out there right now for patients that could be considering these therapies.
Well, I think those are some great recommendations, and we'll certainly link many of those in our episode notes for today. Thank you again so much for sharing your time with us today.
Oh, thanks. It was my pleasure.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.